Hello students, myself Sivaranjani, Assistant Professor, Department of Cardiac Technology from School of Allied Health Sciences, Vinayagar Mission Research Foundation, deemed to be University, Salem. So today our topic is atrial septal defect. So atrial septal defect, it is a congenital heart disease, part of congenital heart disease, and it is an acyanotic congenital heart disease. So before going into atrial septal defect, we will see about how atrial septal forms. Okay, so atrial septal formation, first initiation septum primum grows from the roof. If this is the outer layer of the heart, we could see this is the roof. From here the initiation of septum primum starts, and then ostium primum created, that makes an initial gap. From here we can see an endocardial cushion. From here ostium primum will create, and this is the initial gap. And then septum primum approaches cushion closes, and then ostium secundum forms. Ostium secundum forms from here, and septum secundum forms to right, and then foramen ovale gap persists between septa. So this gap we called as an foramen ovale. And then at birth, functional closure. So after birth, when we see the foramen ovale get closes. The closure of foramen ovale is compulsory after the birth to the child. If it doesn't closes, or the septum primum or ostium primum doesn't develop equally, then this causes atrial septal defect. So what is the introduction? An ASD is a small defect opening in the region of foramen ovale. So as before we have seen, the foramen ovale, if it doesn't develop properly, that causes atrial septal defect. Okay, an abnormal opening in the interatrial septum, which is a congenital heart disease that happens when the septum doesn't form properly. So it occurs 25% in whole children. So here we can see different types of ASDs: septum primum, fossa ovalis, and septum secundum. So next we have the types of ASD, that is types of atrial septal defect. First, ostium primum atrial septal defect, then ostium secundum atrial septal defect, then coronary sinus atrial septal defect, and sinus venosus atrial septal defect. So mostly the most common atrial septal defect is ostium secundum ASD, and later we have ostium primum ASD, then sinus venosus, and most rare ASD type is coronary sinus. Looking into ostium primum atrial septal defect, location of ostium primum atrial septal defect is the lower portion of atrial septum. So here we can see this an atrial, right atrium and left atrium. So here the lower portion is left unclosed. So this is we call ostium primum atrial septal defect. It is near the tricuspid and mitral valve. So associated features or other congenital anomalies accompanying with the ostium primum ASD are complete AV canal defect, tricuspid valve prolapse, mitral valve prolapse, TAPVC and PAPVC. Next we have ostium secundum ASD. So the location of ostium secundum ASD is the defect present in the site of fossa ovalis. Secondary ASD may be single or multiple. So it is when the ostium secundum doesn't develop properly, the roof of the atrium will be unclosed, that causes ostium secundum. So the features that associated with ostium secundum ASD is pulmonary valve stenosis, mitral valve prolapse, Holt-Oram syndrome, partial anomalous pulmonary venous, that is PAPVC. So next we have sinus venosus atrial septal defect. It is located at the entry of SVC into RA, that is superior vena cava. Common entry of IVC at RA IVC type is rare. So where the SVC and IVC enters to the right atrium, that place we can see the unclosed of atrial septal. So that causes sinus venosus ASD. So in the sinus venosus ASD, SVC type, that is superior vena cava type, is more common than inferior vena cava type of sinus venosus ASD. So the associated features are TAPVC, PAPVC. SVC type is commonly associated with anomalous drainage of right upper pulmonary vein into RA, and IVC type is anomalous drainage of right lung into IVC. So this is the image of sinus venosus ASD. So here we can see the presence of RA, LA, and this is this superior vena cava opening. So here is the ASD we can see. By applying color Doppler in this image, we can see the abnormal shunt or abnormal jet through this opening, and that is the shunt or jet of ASD. So next, the last one is coronary sinus, which is the rare defect, any other type of atrial septal defect. So the location of coronary sinus is defect in the roof of the coronary sinus resulting in direct communication with the LA, and it has types, that is complete unroofing CS or partial unroofing coronary sinus. Associated features is commonly persistent with left SVC. So moving on to the pathophysiology of atrial septal defect, the degree of left to right shunting is depend on the amount of blood, or the shunt is depend on defect size, how big or how large the defect is, and then vascular resistance in pulmonary circulation and systemic circulation, and then relative compliance in LV, that is left ventricle and right ventricle. So this is the pathophysiology of atrial septal defect. The shunt is between left to right, as left atrium has a higher resistance, so that passes the blood from left to right, and then volume is overloaded in the right side of the heart, and that causes RA, that is right atrium and right ventricle dilatation, and that causes RV hypertrophy, that is right ventricular hypertrophy. If the right ventricle hypertrophy, then that causes tricuspid valve prolapse, hence it also has tricuspid regurgitation. Hypertrophy of right ventricle causes tricuspid regurgitation, and that causes tricuspid valve prolapse, and that causes again pulmonary hypertension, as tricuspid regurgitation if present, that always causes pulmonary hypertension, that is, or pulmonary artery hypertension. If pulmonary artery hypertension is present, that causes increased blood flow in lungs. Okay, as pulmonary artery carries the deoxygenated blood from the right side of the heart to lungs. If hypertension happens, then the content of blood is a little higher in lungs, and that causes pulmonary hypertension again in the left side, that causes pulmonary vein hypertension, and then pulmonary arteries, capillaries and veins are dilated due to the overflow of the blood, and that reduces pulmonary venous return, and then reversal of shunt, and that causes Eisenmenger syndrome. So ASD later on causes Eisenmenger syndrome. And next we have some clinical manifestation. So ASD is, if it is asymptomatic in infants, that causes recurrent respiratory infections and failure to thrive or arrested physical growth. They might get arrested with their physical growth, and then a pulmonary overcirculation. Left side of the heart get heart failure, thus that causes right side of the heart to work more harder, that causes pulmonary overcirculation. This causes in infants, and in older children they might have mild fatigue, and dyspnea may worsen with their age. So next we have some investigations in atrial septal defect causes, or how can we investigate or diagnose this. Through physical examination, through inspection, normal inspection, left precordial bulges, and then palpitation, prominent right ventricular impulse felt along the lower left sternal border and subcostal. Auscultation may be wide, fixed splitting of second heart sound. Systolic ejection murmur is best heard in left upper sternal border. Short rumbling, mild diastolic murmur is audible in lower left sternal border. So these are the physical examination, and moving towards the chest X-ray. Patient with small shunt, that it might be a small defect in between the atrial septum, so that will be normal when we see the chest X-ray. Patient with significant shunt, that means the atrial septal defect is very large and much large, that might be seen through chest X-ray as cardiomegaly due to the RA and RV enlargement. So next, in electrocardiogram we can see a small left to right shunt that causes ECG is normal. If it is primum ASD, left axis deviation will be present, and if it is secundum ASD, ostium secundum ASD, there may be right axis deviation, right ventricular hypertrophy, right bundle branch block, etc. These changes might be seen in ECG with the patients of atrial septal defect. So next we have echocardiogram, 2D echocardiogram investigation. So mostly atrial septal defect, it is a functional or structural defect in cardiac. So this can be best viewed in echocardiogram and best diagnosed in 2D echocardiogram as compared to any other investigations. So 2D echo study diagnosis, position as well as size of the defect, then enlarged RA, RV, pulmonary arteries, associated anomalies can also be diagnosed through echocardiogram. So here we can see in aortic valve, short axis view aortic valve level, we can see some of the types of ASD like ostium primum, we can see ostium secundum, we can see, and also sinus venosus. These types of ASD can be seen in aortic valve level in short axis image. And next in apical 4-chamber view, we can see the type of ASD like primum ASD, ostium primum ASD and ostium secundum ASD can be seen through apical 4-chamber view. So next in apical 5-chamber view, same we can see ostium primum and ostium secundum type of ASD, and in subcostal view we can see all 4 types of ASD like ostium primum ASD, ostium secundum ASD, coronary sinus and sinus venosus. So the best view to diagnose any type of ASD in echocardiogram is the subcostal view, as it also gives the view of opening of coronary sinus and opening of IVC and SVC. All the type of atrial septal defect can be seen through subcostal view. So next, what is the use of color Doppler in ASD? So color Doppler gives the shunt across ASD and the assessment of pulmonary of systemic blood flow ratio, that is QPQS. Through color Doppler only we can see the abnormal shunt across the atrial septum. So next is pulse Doppler or pulse wave Doppler, reveals the characteristic flow pattern with maximum left to right shunt in diastole. So we can see the direction of flow and the velocity of flow from left to right side through pulse wave Doppler. Then next is transesophageal echocardiography, alternative for older children and adolescents and those who are overweight. It is used to assessing the rims. So transesophageal echocardiography is mainly used for elder children or adults or patients with obese. As 2D echocardiogram we uses through placing the probe in the chest region. In the patients with who are obesity, we might not see clear image, that may be poor window. So through transesophageal, by inserting the probe inside the esophagus, we might see all the images very clearly, and it also helps in assessing the rims so that we can suggest for the treatment. It might be surgical or device closure. So next is the treatment and management. So medical management, like small defect less than 3 mm is considered as patent foramen ovale, hence no treatment needed. As the baby after birth the baby, if it has less than 3 mm of a defect, then this is considered as patent foramen ovale, that it can be closed after 2 or 3 months to the birth of the baby. If it doesn't close, we consider it as an atrial septal defect and we move further for the treatment. Asymptomatic, like no drug is prescribed, it will close in times, as I have already said. And then symptomatic 3 to 5 mm ASD, drugs like beta blockers, digoxin, antibiotic prophylaxis to prevent the infective endocarditis. Antibiotic prophylaxis is given to prevent from the infective endocarditis disease. And 3 to 5 mm ASD with symptoms in the baby, we can give beta blockers, drugs, etc. So catheterization indicated if the shunt is large, that is the QPQS ratio we have measured in pulse wave Doppler, right? So that is greater than 1.5 mm, the diastolic flow rumble in tricuspid valve area, or if the patient is having right ventricular hypertrophy, and the chest x-ray we have seen it diagnosis is cardiomegaly, and echo having right ventricular enlargement. So in this criteria we will move on to the intervention procedure, that is catheterization. Through intervention procedure we place a device to lock left to right shunt. So here we can see before we places the device, here is a large opening is there. This is left atrium and this is right atrium. A large opening is present here. If the rims are adequate and both the rims, it may upper rims and lower rims are adequate and can hold the device, then only we prefer intervention procedure, that is device closure. If the rims are not adequate, if upper one is much longer and lower one is much shorter, then we move on to the surgical procedure. As in this image we can see the rims are adequate, the device is placed. The device is placed, then the lower rims and upper rims can hold the device tightly. Okay, so the types of devices may be used are Amplatzer septal occlude, Gore helix septal occlude, cardio seal device and biostar device. So indication of device closure procedure is secondum ASD. It should be secondum ASD if it is a primum ASD or coronary sinus or sinus venosus type of ASD. These type of ASDs are not fit for device closure. So if it is secondum ASD, that should be greater than 5 mm. Significant left to right shunt with RV volume overloaded. QPQS should be 1.1 to 1 or greater than it should be. Then enough rim, as I have already told, that is 4 mm of septal tissue around the defect. Okay, so these are some of the indications for device closure. Then post device closure follow up. What should we follow up after the device closure or after the procedure? Patient are administered with aspirin 5 mg per kg per day for 6 months. And then echo report should be given, proper mitral valve and tricuspid valve functions, and an obstructed flow of pulmonary vein, coronary sinus and vena cava. And also we check for any other shunt from the device, also be follow up through after the procedure. And next we have the surgical closure. So surgical closure, the direct closure is vortex or pericardial patch we use for the surgical closure. Surgery is performed in medical management and device closure is considered inappropriate. When the device closure is inappropriate, like in ostium primum type of ASD and coronary sinus and sinus venosus type of ASDs are preferred for surgical procedure. Surgical procedure is nothing but in the place of device we will place the patches like Gore-Tex, and pericardial patch will be placed in the place of device as we seen in the previous image. And the complications in surgical may be cerebrovascular accident and post-operative arrhythmia may be came. So follow-up should be proper in that type of patients. So summarizing all the whole topic of atrial septal defect. Atrial septal defect, it is an defect opening in the region of foramen ovale. It is a congenital heart disease. It is a type of asynotic congenital heart disease, and children, 25% of the children may have ASD. Totally it has 4 types of ASDs, that is ostium primum, ostium secundum, coronary sinus and sinus venosus. In investigation we have seen different types of investigation like physical examination, ECGs and echocardiogram. So echocardiogram plays a vital role, or we can say it as a gold standard for diagnosing the ASD. And transesophageal echocardiogram, it is used when the patient are adult or when we get poor echo window in 2D echocardiogram, we will use transesophageal echocardiography, and also to check the rims are adequate or not. And finally the treatment and management, medical management for a small defect patients, that is the defect is lesser than 3 mm. So it is considered at patent foramen ovale, so no treatment is needed till 2 to 3 months. It can get closed automatically. If it is symptomatic, then the ASD is quite larger, 3 to 5 mm. For that type of patients we can give beta blockers and digoxin, and for preventing them from infective endocarditis we give antibiotic prophylaxis. The next is catheterization. So in catheterization, intervention procedure is taking place. So in which that we places device closure is suggested for the patient with the rims are much adequate, and majorly for ostium secundum type of ASD, for that patient we uses device closure intervention procedure. For the patients with ostium primum ASD, sinus venosus ASD and coronary sinus ASD, these type of ASDs patients are suggested for surgical closure. So surgical closure we uses Gore-Tex and pericardial patch instead of device, and complications in surgical closure are cerebrovascular accident and post-operative arrhythmia. So thank you for watching my classes. Thank you.